and welcome to the first symposium of the Vicenza course 2021, sponsored by BIOMERIEUX, and we have the pleasure to host Marlies Osterman and Raji Basu, good friends and colleagues. We have shared several activities, papers, research, consensus conferences, and they will present a very interesting initiative, which is basically an AKI awareness campaign. So without no further ado, Marlies does not need any introduction. She is the top lady in the area of AKI and the top friend, I must say also. So Marlies, do you want to share your screen and start your presentation?
Thank you, Claudio, for this wonderful introduction. It's a great honor to contribute to this symposium, and I would like to thank you for organizing the Vicenza course, and I would like to thank BIOMERIEUX for organizing and sponsoring this important campaign. In the next 10 minutes, I will set the background to this initiative, which Professor Ronco already alluded to. These are my disclosures. Acute kidney injury has clearly emerged as a serious condition with very important, occasionally life-threatening short and long-term complications. Numerous landmark studies have confirmed that acute kidney injury is a problem worldwide, and it affects people of all ages. It is estimated that 1 in 4 people develop acute kidney injury during critical illness. And patients with acute kidney injury have a higher risk of dying. The risk of dying is particularly high in those with more severe acute kidney injury. In fact, most recent data suggest that more than 13 million people are diagnosed with acute kidney injury each year worldwide. And acute kidney injury causes an estimated 1.7 million global deaths per year. So it is a major problem worldwide. If we look at more national data, for instance, data from the US, then again, we can see that acute kidney injury is common, and the risk of dying is higher in those with more severe acute kidney injury. It's alarming to see that the risk of dying from acute kidney injury is higher than that of many other common conditions like heart failure or diabetes or breast cancer. And it will come as no surprise to hear that acute kidney injury increases healthcare costs, and that people with acute kidney injury consume a lot of healthcare resources. And this obviously leads to increased costs in the healthcare system. When this was realized in the UK, acute kidney injury was termed a killing illness, and clinicians, but also healthcare administrators were urged to put everything in place to prevent this silent killer. Because it was felt that preventing acute kidney injury would not only save lives, but also reduce the risk of morbidities, and it would reduce healthcare costs. And at that time, it was estimated that the costs of acute kidney injury exceeded those of the cost of the most common cancers. It was very concerning to see that acute kidney injury not only affected a lot of patients, but 1 in 4 cases of acute kidney injury were considered to be preventable. And preventing acute kidney injury obviously would be associated with a reduced mortality. It would mean saving lives, reducing comorbidities, and potentially saving money. And it was estimated that the prevention of 1 in 5 cases of acute kidney injury could save the healthcare system up to £23 million. And then the health economists went further and said, if this money was saved, then up to 600 nurses could be employed. And clearly this would be a major benefit for the whole population. So it's a major problem worldwide. And in many countries, campaigns, initiatives were founded to address this. For instance, the American Society of Nephrology founded the AKI'Now initiative, an initiative with the aim to raise awareness and improve education. And the team clearly recognized that at the heart of this was education and training. And they felt that education was needed at all levels, from patients to clinicians to administrators to lay people. And they proposed that education and training and guidance would ultimately then also lead to better management and, importantly, better outcomes of patients during critical illness. A similar initiative was developed in the UK a few years ago. It was called Think Kidneys. And again, they acknowledged that education and training were the most important aspects to improve the management of acute kidney injury. And they set themselves the target to improve education globally at all levels, including lay people. To really understand how important education and training was, they started off with a survey to explore the current understanding of kidney disease and asked people in the street very simple questions like this one: which, if any of the following things, do the kidneys do? It was shocking to see that just over 50% of people in the street knew that the kidneys were organs that made urine. Although it was shocking, it was important to be aware of this knowledge gap, because it then led to awareness campaigns, educational projects, and ultimately improved the understanding of not only kidney function and health, but also raised the awareness of acute kidney injury, introduced the concept of important of volume depletion, of diarrhea, and medication management during critical illness. So this was done in the UK, a survey amongst lay people. The next question is are there any knowledge gaps amongst clinicians? And that's an important question, because AKI develops in all specialties. In fact, AKI is much more common outside critical care and outside the renal unit. And therefore, it is important to identify potential knowledge gaps so that they can be addressed. For instance, do healthcare providers, non-nephrologists, non-intensive care clinicians, do healthcare providers understand the limitations of the current definition of acute kidney injury? Are they aware of the shortcomings? The fact that creatinine is not renal specific, but it is affected by muscle mass and fluid status. Similarly, are non-renal clinicians, non-intensive care clinicians aware of the current guideline? Now, this is the KDIGO guideline for the management of acute kidney injury. It's almost 10 years old. It's well known amongst nephrologists and intensive care clinicians, but do non-nephrologists actually understand and follow this guideline? And this is an important question, because we need to understand where the knowledge gaps are so that they can be addressed. And by addressing them, obviously it provides opportunities to improve management and ultimately to improve the outcome of patients at risk of acute kidney injury. And without further delay, I'd like to now hand over to Professor Basu, who will follow on from this.
Thank you, Dr. Osterman, and thank you, Dr. Ronco, for this invitation and for this opportunity to present the symposium. I'm going to share my screen, so Dr. Osterman, if you wouldn't mind stopping your share. Perfect. Okay, so what I'm going to do is take the baton that Dr. Osterman has kind of given to me and run with it, and describe the awareness assessment that Dr. Ronco presented at the beginning of this session that was completed by Dr. Osterman, Dr. Ronco, and Dr. Mehta and myself this past year. I will say these are the disclosures of mine, and also that the project I'm about to describe was supported by BIOMERIEUX and executed by the Ipsos survey folks. A more important disclosure is that I really wish we were there in person. Someday we will be back together in person. This is a study that is not yet published, but I want to go and describe the answer to the question that we proposed, which is, if only 50% of the lay population understands the basic truth that the kidneys make urine, are we to assume that our colleagues who are not nephrocentric, either not nephrologists or not critical care nephrologists, know anything more or know anything better? Because if they don't, then we really do have a big education problem on our hands, which may be part of the big problem we have. So what we did was we designed a survey that was a study of healthcare providers in the adult medicine paradigm across different subspecialties. And we wanted to assess awareness with 5 different kind of categories or paradigms: the familiarity with AKI itself, how people define AKI, how people recognize AKI, what they do if AKI is recognized, and then what the long-term consequences are. So through a survey of people who already existed in the Ipsos database, we queried about 1,000 different healthcare providers. Half were in the US and half were spread across 5 different Western European countries that you see described here. We surveyed intensivists and nephrologists to serve as what we would have considered as positive controls for our experiment of awareness. And then we surveyed 3 different subspecialists that all came across patients in our mind of AKI in some aspect of their daily care work paradigm, whether they were acutely presenting in the emergency room, whether they were consulted on these patients as cardiologists or presented in the cath lab, or if they were internal medicine hospitalist physicians taking care of otherwise sick adults in the wards. There were some screening criteria that they had to be on service a certain amount of time and in a hospital that had the exposure to emergency department, et cetera. And so the breakdown was more or less even across the distribution. Here are the demographics of the people that responded to the survey that we created about AKI awareness. As you can see, they were spread across the different subspecialties. They came from hospitals of varying ICU size, varying total bed size, but a majority of them were from very large hospitals, of over 500 beds in the hospital. Most of them saw at least 90 to 100 AKI patients in a typical week. And there were not very many that were pediatric practitioners, and I'll get to that, even though I am a pediatrician. What we found was that nearly all healthcare providers agree that AKI is often missed. Actually, over 50% of healthcare providers believe that AKI is missed. And if you look at where we kind of drew the arrow here, what it says is a specific question about diagnostics, which I'll get to shortly, about the changes in urinary output being not sensitive nor specific for AKI. But if you look at the line below that, you'll see that current methods for the diagnosis of AKI mean that it is often missed. This is a statement where people had the choice to say either agree or strongly agree, and also the opposite, disagree, strongly disagree. But more than 50% of people believed that AKI was commonly missed in the hospital. More important, 1 in 3 would like to learn more about diagnostic methods and tools to manage AKI patients. As you can see, we queried deeply about the information desired to improve management of AKI, and you can see that more than a quarter wanted more diagnostic information. Many required more information about treatment and patient care measures, and some wanted more information about monitoring and biomarkers. There is a perceived need for better better and early detection of AKI. You can go through each line here, but the point of this is very clear in that there is a lot of indication across disciplines that detection of AKI is lagging. And part of the reason that we are suffering in our management of AKI is really based in diagnostics. If we think about in kind of a secondary question about the proportion of AKI cases that could have been prevented, 34% of responses, or of the respondents, they indicated 34% or a third of AKI cases could have been prevented. Now, it's important to put this into context, because if you ask those people that were queried in the Think Kidneys statements, research project about, if you said a third of heart attack cases could have been prevented, a third of stroke cases could have been prevented, a third of car accidents could have been prevented, what would they say? And we often don't talk about this issue, that we have cases of AKI, or we have patients that we miss, that we wish we would have missed, saying, oh, well, you know, this is the situation, we have this learned helplessness. But this is not okay. Any other disease process, any other condition that the public knows a lot about, this would not be acceptable. And as Dr. Osterman pointed out, with the KDIGO guidelines, very few of the healthcare providers who answered this survey actually are using those guidelines for either detection or management or treatment of AKI. So these are 10 years old now, and less than 50% of providers are using these or know about these. So again, if you put this into perspective or compare it to things like door to cath time for STEMI, sepsis and early goal-directed sepsis therapy, or surviving sepsis campaign guidelines that have recently come out. If you told me less than 50% of people responsible for managing STEMI or sepsis are using indicated guidelines, that would be a problem, but this is the truth of the matter for AKI. A big problem that we probably are recognizing more and more now is this issue of AKI leading to chronic disease. And overall, what we found is that only 7 out of 10 healthcare providers associate AKI as a condition that leads to chronic disease, meaning that 30% of people, and this includes nephrologists, do not believe that AKI leads to any kind of chronic disease. If we group all of our data about AKI impact, and we compare subspecialties, so nephrology ICU is our quote positive control to cardiovascular subspecialists, hospitalists, emergency medicine docs, and then by region, what we find is remarkable discrepancy in actually even what AKI is called. There is a wide range of terminology and nomenclature used, even though AKI has been a term that has been in place for the last 15 years. If you lead to that chronic illness category, you see that people have a stronger suspicion that conditions such as stroke and MI lead to chronic disease. If you look at the CV hospitalist ED population, you see what a discrepancy there is between percent of respondents that believe those lead to chronic conditions versus nephrology and ICU, who serve as our control. If you think about current state, and the current state is about diagnostics, it's about management, it's about people at risk. What we find is that even amongst nephrologists and intensivists, a third of people believe that tools are insufficient, that creatinine and urine output are not sensitive nor specific on their own. And ED physicians, hospitalists agree with this. But the problem is that if you look at who they talk to and the guidelines that they refer to, they're all over the map. And actually, they don't use the guidelines and the recommendations that are in place. More than half of them in most cases. And this has no geographic, preference or anything, because it's both in the US and in the Western European countries. What can we do? If you ask these subspecialties and disciplines about what could be done for AKI, what you find is what I had alluded to before, nearly 100% of them indicate more education is needed, and more education and earlier detection could lead to better outcomes, that knowledge is power. And if you think about this, what you find is that the perception of things like creatinine and urine output is very consistent in the sense that even though that people think we don't know enough or diagnostics are bad, this is what we use. The perceptions are really, in a nutshell, we have bad tools, but we're going to use them anyway. Or we have insufficient tools, we're going to use them anyway. We miss a third of cases of AKI. Oh, but what can we do? We're going to use these anyway. This is what we're finding amongst healthcare providers. And if you do a sequential cumulative agreement between questions that people agree with, saying that AKI is bad, our diagnostics are imprecise, we frequently miss cases, our tools are insufficient, diagnostics lead to bad outcome, but if we have better diagnostics or earlier diagnosis itself, we could have better outcome. What you see is a clustering so that those people who generally see a lot of AKI, the ICU, cardiovascular physicians, and nephrologists, are all about 20% to 30% higher in agreement with all these statements than the ED docs and the internal medicine docs. But you can make an argument that the ED docs and the internal medicine docs are as important or more important for early diagnosis and early recognition of AKI. They're the ones who need more education because they're the ones who are at the tip of the spear most of the time. So our take home from this survey is very clear that healthcare providers across disciplines feel that AKI is an important contributor to morbidity and mortality. We are wholly inadequate in our recognition of AKI and assessment of diagnostic adequacy, and that opportunities are clear for a provider discipline-based approach, that the approach that is recommended and guidant for an emergency room physician should be personalized to that field of medicine. And speaking of, we didn't query pediatricians at all. And as a pediatric intensivist, I will tell you, it's important to recognize that children suffer AKI on the same scale as adults, but commonly lack many of the comorbidities that exist in adult patients, meaning that AKI itself is the contributor to their poor outcome. We have a brewing epidemic in children who have CKD, even though they go unrecognized. And as a father of 2 young kids, this is very important to me that things like proteinuria and hypertension in childhood are not ignored. Existing diagnostics may be even more compromised. Serum creatinine is even more compromised in children across ages when that's the only adjudicator of AKI that we have. And our awareness in pediatric medicine has not really fully been explored outside of a few isolated studies. We have lots of work to do. This is a figure that just got published. Dr. Osterman, Dr. Ronco were heavily involved in the AKI-23 that put this out to integrate biomarkers. This is the recommendation. The recommendation for using AKI is 15 years old, and as you saw, many people don't use that. The recommendation for the KDIGO bundles is 10 years old. Many people aren't using that. This came out. How long will it take people to integrate this? We have to be the charge to not just educate each other, as wonderful meetings like this are dedicated to, but to spread beyond our doors and beyond our borders, because there is a big knowledge gap. We must help our non-intensivists and non-AKI centric nephrologist colleagues learn and be more aware of AKI in all aspects if we are to reverse this epidemic. And I thank you for this opportunity.
Well, thank you very much. Of course, I share 100% what has been presented, also because we work together in this project. I have a quick question for both of you, because we don't have too much time. In the past, people in our region asked to do a kind of AKI registry. And we did in the past, but we only did looking into intensive care, cardiac surgery, and nephrology only for those people who really require dialysis. Now, when this was reproposed 10 years later, I refused to do this unless we wanted to take into account also stage 1 and 2. Although we know the stage 1 may be very sensitive and not necessarily too much specific, however, we know how much burden and how much workload this represents for physicians in the hospital, because these conditions require attention, require consult, require management, possibly to prevent evolution into stage 2 and 3. Now that we have even more capabilities to somehow recognize AKI. And in fact, the latest consensus conference we did and published in JAMA that you alluded to include the stage 1S, which is a stage in which only biomarkers are positive and creatinine does not reach the threshold for the classic KDIGO classification. What do you think will be the main message to convey to make people understanding that the perception of AKI and the perception of the workload imposed by AKI, not necessarily stage 3, represents in the hospital? I think we need really to work to make people understanding that there is a kind of 30% of patients admitted that may develop some form of AKI and need to be taken care. So what could be the message that we can distribute and disseminate? Marlies?
It's such an important question. And you're raising such an important point. In the UK, it was proposed to have an AKI registry, and hospitals were strongly encouraged to contribute. And at present, less than a third of hospitals are contributing because it is not automated yet, and it is creates a lot of work. So there needs to be a system that makes collects the data automatically for a start, but that shouldn't stop us because it is so important. And I think the next step to get us to what you're proposing is probably to educate and raise more awareness about amongst patients, because I've now heard several patients who said to me that they by chance had found out they had AKI and nobody had told them, and were they not informed, and what did it actually mean? And I think if patients insist that AKI is diagnosed, that it is in the discharge letter, and that it gets registered properly, then healthcare systems and hospitals have no choice but to register the data. That's how I think we need to empower patients to demand this information.
Raji, I think this reminds me very much when we started classifying chronic kidney disease into 5 stages, and the people said, colleagues actually said, oh yes, but if you classify also stage 1 and 2, we will be flooded by a large number of patients that require consult and so on. But today we know that if we take care of stage 1 and 2, we may really slow down the progression of chronic kidney disease. So I think that for AKI is exactly the same thing. What do you suggest to try to increase awareness and alertness?
Yeah, I think the question is similar. My answer to that is similar to Dr. Osterman's response. And I would say this, in 2012, one of my favorite editorials of all time was written. This editorial is printed and put on my door, and it was published in JAMA by 3 gentlemen, one of whom is on the screen right now. And the headline was Kidney Attack. And in my mind, as Dr. Osterman so well put, if you make the public aware, what will happen is not just pressure, but there will be all of a sudden a groundswell of resources and support that physicians and hospitalists need, and let's be transparent, money and people to do the work that needs to be done. Because as I pointed out, this paradigm that we live in would simply not be acceptable in other diseases that have much more publicity and much more press, and that you go to the grocery store and they ask you for $1 for this kind of cause. We should be out there doing the same thing. And when I say we, what I mean is all healthcare providers, and not just nephrologists and not just intensivists, because when we have that amount of resources, those are the things that will help us create registries that will increase the web and the bandwidth to capture those patients in real time at early stage and do the things we need to. It's just that, you know, are currently still in the realm of talking to each other instead of getting out and saying, you know, most emergency room physicians are, you know, need help and they don't know that they need help. A lot of nephrologists, a lot of intensivists need help and they don't know that they need help. But I think that's the way to go. And it takes provocative pieces like the one that you wrote with Dr. Kellum and Dr. Beloma that will trigger this for people.
Well, we could not open with a more actual and more important topic, our Vicenza course. And as you mentioned, I hope that in 2022, we will all meet in person in Italy, in Vicenza, for the 40th anniversary meeting. Nevertheless, in the meantime, we need to go probably on TV shows, on newspapers. We need to go public on this concept, and the work has been done is just outstanding. Looking at it, I rethink that this would be perfect for Lancet, but still we need to convince people that this is important. So thank you very much to Raji. Thank you very much for Marlies, and we will go on with the scientific program.